So we're going to start with the palpebromalar groove. The palpebromalar groove is an area on the inferolateral side of the orbital rim where there is most significant bone resorption. So during the aging process, a loss of volume occurs around here. And therefore, there's a hollowing because while the bone descends, it will pull on the orbicularis retaining ligament. The ligament, the ORL, is attached to the skin and goes down to the bone. So the bone will pull the ligament and thereby will create this groove in the skin, this hollowing over here. Of course, this is a circular ligament going all the way around the orbit with only one opening, which is in the supraorbital foramen. The danger zones in this area are the zygomaticofacial foramen, which is approximately here in the bone, and, well, quite far away, the infraorbital foramen, which is over here. Of course, there are arteries on the periosteum and coming out of the bone, out of the foramen. So these are the main two arterial danger zones. Then, of course, there is the intraorbital danger zone. We are, of course, limited by the extraorbital area. So we have to be, let's say, distal to the orbital rim. So that means we should not inject into the orbital area. And therefore, we have to choose a way of injecting into the palpebromalar groove that will reduce or limit the risk of intraorbital deposition of filler. And so we could use a cannula technique, and let's say theoretically you could use a cannula and go from here and place your product like this. But you have to be careful to not go with your cannula through the ORL into the intraorbital area. Or you could place a cannula, let's say here, and go slide against the attachment of the ORL to the periosteum of the orbital rim. And maybe that would be 2 entry points. Alternatively, you could take a needle and go with the needle directly to the periosteum and place multiple little deposits over there. So in this case, I will choose a cannula technique, and I will have the approach from here. And I will talk a little bit about how to prevent intraorbital placement of filler. Now, what's important with treatment of this area is disinfection. And I will give her a little drop of lidocaine. 1, 2, 3. Right over here. This is lidocaine with adrenaline. And then also on the periosteum, I will inject a bit of lidocaine, first of all for anesthesia, and second of all for creating some space, hydrodissection. So 2 little blebs, I kind of massage the lidocaine over the periosteum. Now, I will choose a 25 gauge cannula, and so I will make an opening in the skin with a 23 gauge needle. Make a little opening. And then I will introduce my cannula. Now this is calcium hydroxyleptide containing lidocaine. And so I have not mixed it with lidocaine. So this will give me the full viscosity. I want to be down on the periosteum. And as you can see, I'm lifting the tissue and then go through the resistances until I feel that my cannula is actually in direct contact with the ORL. It's on the periosteum, and I'm being stopped now in my advancement by this ORL. So that means that I have advanced as far as I can. Now I will place the opening of the cannula down to make sure that the product is being injected exactly on the periosteal level. And I'll place a tiny little aliquot, 0.05. I retract reorient over and re-advance over the periosteum. And until I feel again with my non-dominant finger here on the infraorbital rim that my cannula is touching my finger. And again, I place a little aliquot, a little bolus of 0.05. Retract, reorient. And while lifting the tissue in order to stay on the periosteum, sometimes it's necessary to rotate a little bit to make sure that you pass these little resistances over here until I feel again the cannula touching the tip of my index finger of my left hand. Bevel down, and again 0.05. And so I continue, lift up the tissue, advance the cannula, and of course I have to be sure not to go through the ORL. It's possible, of course, to go through the ORL. You'll be injecting into the intraorbital fat, which is definitely not the intention. So as you can see now, there is much less of a palpebromalar groove here on the right-hand side. It's a safe technique, but you have to be aware of the danger zones. And of course, the main danger zone is going into the orbit. Maybe I will place just a little bit more here. So lift up again. Advance the cannula over the periosteum. All right. So I have now injected about 0.25 milliliters of calcium hydroxylepidide containing lidocaine.